Hi, I'm Akshay Khandelwal. I'm an interventional cardiologist and the Associate Division Head for Cardiology at Henry Ford Hospital. I'm part of the Henry Ford Medical Group, which represents 2,500 physicians, physician scientists, fellows, residents, and advanced practice providers. We're part of the Henry Ford Health System, which is a 5-hospital system in the southeast Michigan area, one of the current COVID-19 epicenters in the United States. There are several ways that COVID-19 is affecting our cardiovascular patients. First of all, many of them are concerned, scared, and frankly misinformed about COVID-19. Our frontline staff, including our CV team, our residents, and our fellows have done an amazing job in ensuring that our patients are provided the best education possible so that they can personally protect themselves and take responsibility for preventing spread. Secondly, we've had to encounter many delays in either testing, procedures, or office visits. Now, sometimes it makes sense. Somebody who is being seen for asymptomatic mitral regurgitation probably can wait several months before being seen or getting a follow-up echocardiogram. However, what do you do for patients who are on the liver transplant list with a high MELD score that need further cardiovascular testing or investigations? What do you do for the patient who is symptomatic with severe aortic stenosis and is in need of further imaging or a TAVR? Prioritizing those procedures and testing and office visits can sometimes be very stressful for patients. And finally, we've been rather successful at implementing virtual care throughout our health system, either in the form of video visits or telephone visits, but we do run into challenges sometimes. Some patients have trouble with connectivity because of a poor broadband connection. Sometimes our elderly patients are less comfortable with technology, and sometimes socioeconomic challenges in the southeast Michigan area just make it disadvantageous for us to implement virtual care. There are at least 3 ways that we have undertaken to protect our cardiovascular staff from the risks of COVID-19. First of all, our health system has provided surgical masks for all employees, which I think is very critical. In addition, for those who are in contact with patients who are COVID-19 positive, suspected of having COVID-19, or are in high-risk positions, they are provided an N95 mask, some protective outerwear, face shields, and other PPE. Secondly, we've done a great job, I think, in social distancing, primarily through instituting virtual care throughout our health system. On top of that, we've gone to a block model schedule for many of our physicians. So, for example, you can spend a week in clinic, sort of a low exposure risk for COVID-19, a week in the echo or cath lab, which is a more moderate level of exposure for COVID-19, and then finally a week on the inpatient rounding service, which most of us would agree is a high risk for COVID-19 exposure. And then we recycle them back again. That allows them to deal with fatigue as well as create sort of a reserve bench if somebody gets ill or has to be put into quarantine for symptoms. Finally, we've taken a deliberate focus to ensure that all of our physicians, fellows, residents, and APPs maximize their wellness. That's one of the reasons that I'm talking to you today from a nature setting along with my family. We've realized that it's very important for people to be able to rejuvenate themselves and reflect on their life in order for them to be re-energized and refocused on the hard work ahead. So if we knew a month ago what we now know, what might we have done differently? First of all, I wish we had more widespread availability of testing, and that too testing that has a very, very rapid turnaround. We would have been able to test all symptomatic patients and employees who have been in contact with either COVID positive or suspected COVID-19 patients. Secondly, it's interesting that COVID-19 can masquerade as many common cardiovascular syndromes. So even though you think you may have a patient with heart failure or acute coronary syndrome or even idiopathic pericardial effusion, you need to check for COVID-19 in the unlikely event that they actually have coronavirus. And if your test is negative, yet your suspicion is high for COVID-19, test again, because we've encountered many false negatives. Third, I think it's important to build a virtual care platform. We certainly were able to quickly transition to virtual care, but had we had a plan in place earlier, I think we would have done a more successful job in implementing our virtual care delivery system. Fourth, it's important to make sure that you not only have a plan going into this, but recognize that your plan can change from week to week. Your inpatient, outpatient testing and procedural footprints will look very, very different depending on what side of the slope or curve you are on as far as the COVID-19 buildup of cases in your area. And finally, I wish I had gotten a haircut. Thank you.